Well, what are medical homes? Well, medical homes have actually been around for probably 10 or 15 years in some form, and this is just a way of looking after the chronically ill patients by having a team also. Now, the team here may include all sorts of support organizations as well as providers in doing that, and it does involve, if you're going to do that, you have to have in your medical home health information technology. You do have to have electronic medical records or you cannot be a medical home. Now, an individual doctor can be a medical home, although that person's not going to be very well looked at by the government unless it's a superman or super lady that can do everything. You can have medical villages. You might have a group of urologists that can be a medical home just looking after the urological needs, or you may have medical cities. You may have total groups like the Mayo Clinic has, sort of like we have at UNT Health, where you cover everything under that umbrella. But a medical home can be any of these. Now, the rules and regulations of the medical homes and the accountable care organizations have not yet been totally written, and they're in the process of being written now. Bundled payments is sort of the concept of bundled payments as it exists in the bill, and there's two demonstrations that will be going on, is basically for the hospitals. In other words, if a patient comes into the hospital for the period of 3 days before and 30 days following discharge, any bills that are incurred by that patient, one check will be written by the government to somebody. We don't know yet who it's going to be written to. You might guess who it's going to be written to, and I think we're standing in one of those buildings, probably hospitals. And that hospital then, or that organization, must have a mechanism for paying all of those bills. What does this mandate? You better get to know your hospital administrator really well. And you better take them out to lunch. Hospital administrators like lunches. And take them out to lunch and become their best friend, because that's who you're going to be negotiating. Also, everybody in this room is going to be negotiating with each other to figure out what % of the pie that they get. And so the idea of a fee for service where the government writes you a check for doing the hysterectomy or doing the cystoscopy no longer exists, because there's the surgeon, the anesthesiologist, the lab, et cetera, et cetera, et cetera. And so one check will be written. Now, everybody believes, although that is what is referred to as bundled payments today, everybody believes, or I think most people believe, that the same methodology will be used to pay on an outpatient basis. So when you hear about bundled payments as it pertains to the bill, it's only in hospital patients, or in the period 3 days before and 30 days after. But, in fact, they believe that the bundled payment concept will also be used outside. So, for the outpatient. So what does this mean? That these new models favor dramatically a hospital-physician alignment, so that the two work very closely together. The government is absolutely convinced that if doctors and other providers are forced to work in this atmosphere with the hospitals, that there'll be much less duplication, there'll be much less, there'll be many less errors in practice, everybody will take their job more seriously, and they will save a lot of money. Now, in the bill, there are rewards for being primary care and being chronic care. Now, I love this one. And when I first read that, I thought, general surgeons come under the classification of primary care. And they will get a 10% bonus if they're doing their surgery in an area where they're underserved. What does that tell you? It tells you the surgeons had one tremendous lobby to get that put in. So people who work, primary care physicians who work in underserved areas will get a 10% bonus, and that will include the surgeons. The states, the federal government will get 100% match for these, and they really would like all of this primary care and chronic care management to come under this concept of medical homes and accountable care organizations, however they end up in their final form. As I said before, under primary care will come the health plans having to cover their patients for the various screening methods without any copay. Same thing with prevention and wellness. There hasn't been a plan, and there hasn't been anybody talking about health care that doesn't push the prevention and wellness. The problem with prevention and wellness, there's nothing in the bill that forces patients at all to live a better life or not be insured. So as long as we have excessive use of drugs, et cetera, this is going to be a very hard one to sell. There's a tremendous amount in this bill on quality, and there are numerous national programs that are now being set up that will institute a variety of quality initiatives. And for the accountable care organizations and the medical homes and the groups and the hospitals, there will be great reward for showing that you're practicing high quality medicine. Now, that does take a tremendous organization on the part of all these, because there'll be many benchmarks that you'll have to submit, that we'll all have to submit to show that in fact we are practicing that high quality. They fully believe that the accountable care organizations, the medical homes, and the bundle payments will lead to higher quality. There's no question in their mind. In addition to that, they are, In addition to that, they are establishing a hospital value-based purchasing program that will be expanded to nursing facilities and home health agencies to pay hospitals on the basis of quality measures. For example, I think you've all heard that if your patient develops an infection while in the hospital and it requires an extra 4 days of staying in the hospital, they're not going to pay for that, because they believe that is due to the laxity on the part of both the physician and the hospital, and it's not their job to pay for poor quality. So that's one example of what they're planning on doing. As far as physicians are concerned, there is going to be, we're all going to be advertised on the internet. There will be several benchmarks that we will have to report. For example, for OBs, their cesarean section rate, their postoperative complication rate, their readmission rate to hospital within a certain number of days, and this will all be reported on the internet. It will not only be for Medicare patients, but it will be for all the patients from all the other payers as well. We will be able to review our ratings before they go on public, but we can't change them, obviously. And it'll be our information that we supply. And if you don't supply that information, we're going to look kind of bad amongst the patients. And I think, as all of you know, there's already probably 11 sites on the internet where patients can go and put comments in about us, and other patients can go and review those comments. And if you haven't visited those sites, just punch your name in sometime, and see what people might be saying about you. The law directs that this site was launched on January the 1st, so it is already in existence. They're putting the data in, but I haven't gotten any requests for any benchmark data yet, so I don't think they put a whole lot of data in yet. But they will be asking for this data. The data will go in, and it will go live on January the 1st, 2013. So if a patient's looking for a physician and they find you've been recommended, they can go to this site and they can find out what your cesarean section rate is, what your complication rate is, et cetera, et cetera. Now, they are still working on all the data they want. As you might expect with this bill, there was almost nothing on medical malpractice. Certainly the bill we have in Texas is very good, but there's nothing in this bill that really is a problem to our bill. Remember that if anything in a federal bill it supersedes anything in the state bill, so we could have had our whole bill wiped out if they had put some fairly lame bill into it, but they did not. It was better they didn't if they're not going to put a good bill in, because it would have wiped our bill out. And so our bill is safe, and all they have is demonstration projects. Financial disclosures is everything. You know, now if you do anything, you got to financially disclose. And of course, they close the loop on any physician. Medicare will not contract with any doctor who is part of any physician-owned hospital after December the 31st, 2010. So that's already in place. Now, what are the strategies then? Those are the facts. That's what's in the bill. One of the things that I would say first, and as I go around giving these talks, I still run into people whose number one question is, when is the bill going to be repealed? When are we going to get back to sanity? Well, I would suggest that you separate your personal political views on what you think of the bill from the reality that the bill is already the law of the land. And it's been in existence almost a year, 6 months. And remember, most of the things that went into effect on September the 1st. So I just would suggest that just separate your personal views from the reality of what's going on. The second thing, and I think that's become very clear in the last 3 or 4 months, is that that bill is only the first step. That bill could get totally repealed by the Supreme Court. And of course, there's a lot of juggling right now with the appellate courts, 2 of them ruling in favor of it being constitutional, 2 of them saying it's not constitutional. And no doubt it's going to come to the Supreme Court. The Republicans are trying to get it to the Supreme Court tomorrow. The Democrats want to get it in about 2015, and they hope they would have a better court by then. So you're going to see all sorts of juggling on the part of both parties, but I don't think anybody expects that it'll go in 2011. I think 2012 would probably be the earliest you get any ruling on this. Well, at that point, the bill would have been in place 2 years. And it's hard to just repeal a whole bill. What are you going to do with people who already have state insurance? Are you going to tell them their insurance company is no longer valid? So there'll have to be ways of making those insurance companies legal under some other system. So you just don't wipe out a bill that's already been in existence for a couple of years and affect people's lives accordingly. Study the legislation from the standpoint of your practice to identify where it might be of some help. There's a lot of money in this bill that is being given out for projects and quality, for medical homes projects, accountable care organization projects. And so there is before you dismiss the bill, look into it as to how there might be things that would allow you to be creative in your practice, especially if you're part of a bigger group. Understand that the changes that will increase access. We've been through all of these. They are significant. There are going to be 40 million new insured patients that are not insured patients. And in Tarrant County, there's going to be something like 400,000 or 500,000 new patients that are looking for doctors. And so you want to have yourself out there as a viable alternative for those patients. As I said, a third of those will be Medicaid, so even those that don't like Medicaid, there's still 2/3 of them, 24 million, that are going to have new health insurance.